Good day, everyone, and welcome to today's Approaching Medicaid Tobacco Cessation, a Focus on Providers conference call. At this time, all participants are in a listen-only mode. Later, you'll have the opportunity to ask questions during the question-and-answer session. You can chat your questions in the Q&A box located on the right-hand side of the presentation. Please note this call may be recorded. I'll be standing by should you need any assistance. It's now my pleasure to turn today's program over to Ms. Tamitha Thomas-Hassey. Please go ahead, ma'am.
Thank you so much, Roxana, and welcome to all of you to the webinar today, sponsored by the American Lung Association, Approaches to Promoting Medicaid Tobacco Cessation, a Focus on Providers. I have the great pleasure of facilitating the session today, and before we move to an introduction of our presenters, I'd like to introduce Anne DiGiulio. Anne is Manager of Lung Health Policy at the American Lung Association, where she heads up the Tobacco Cessation Policy Project, which includes managing 2 federal grants relating to the Lung Association's tobacco cessation work. Anne is also responsible for the technical assistance to the field on tobacco cessation issues, including developing resources and fact sheets. So Anne, I would love to turn it over to you at this point to take us through our agenda for today.
Thank you, Tamitha. Great. So Tamitha is just going to, once I'm done going over the agenda, Tamitha's going to turn it back over to her, where she'll introduce our speakers. And thank you so much to our speakers in advance for participating. We could not do this without you. And then we're going to set the stage a little bit about what tobacco cessation is like, what the atmosphere is, what the agenda is, and kind of what the atmosphere is. And then we're going to hear from Vermont and hear about their efforts to promote tobacco cessation in their Medicaid program, specifically to their providers. And then we're going to hear about Wisconsin's approach. And then we're going to have a chance to take some questions from everybody. So please feel free to type in questions in the Q&A box, and we will, and as soon as you have them, so throughout the presentation, then we'll try to get to them at the end. So that is our agenda today. Tamitha, I'll turn it back over to you.
Okay, wonderful. Thanks. And let me just reiterate Anne's point to the speakers. Certainly, we are feeling extremely lucky to have these 3 folks with us today to share with us Vermont and Wisconsin's approaches to focusing on providers and promoting, especially promoting tobacco cessation to those who are serving Medicaid members. So first, let me introduce Rebecca Brooks. And over the past 30 years, Rebecca has built capacity for, trained, and provided technical assistance in the areas of tobacco control, obesity prevention, healthy sexuality and teen pregnancy prevention, and civic engagement, both nationally and internationally. She's worked with USAID, the Ford Foundation, the U.S. Embassy, the National Campaign to Prevent Teen Pregnancy, New York State Tobacco Control Program, Planned Parenthood Federation of America, where she was also the National Director of Social Marketing there, as well as the International Planned Parenthood, among others. Currently, she's on the editorial board of the Social Marketing Quarterly, which is a peer-reviewed, internationally distributed professional journal, and is currently the Director of Chronic Disease Information in the Division of Health Promotion and Disease Prevention at the Vermont Department of Health. And today we have Rhonda Williams joining Rebecca. Rhonda is the Chronic Disease Prevention Chief, where she oversees the Tobacco Control and Prevention Program in Vermont. Her areas of focus for the tobacco program include policy, health systems, and strategic partnerships with the aim of reducing health disparities in the low-income mental health and co-occurring populations. And next, we're joined by Rob Adsit. And Rob joined the University of Wisconsin's Center for Tobacco Research and Intervention in 2004, and there directs the statewide clinician education program, including management of regional outreach specialists located across Wisconsin who provides medical education outreach with healthcare professionals and systems. Rob has a bachelor's degree in business, a master's in education, and his experience includes educational program development and implementation, training, and technical assistance in the areas of tobacco control and alcohol and drug abuse. He has a strong interest in health and economic disparities, diversity, and inclusiveness, and his current work focuses on using the electronic health record to identify and treat patients who use tobacco, as well as implementing changes in healthcare systems to make evidence-based tobacco cessation the standard of care. So I welcome all of you to the webinar today, and we are certainly excited to hear what you have to share with all of us about your important work. So Anne, at this point, I'll turn it back to you to help us set the stage for the presentations today.
Great, thanks, Tamitha. So I am just going to set the stage as soon as I can move the slide. There we go. Okay, so what do we know about tobacco cessation and our Medicaid population? Well, we know that people on Medicaid tend to smoke at a higher rate than the general population and the population with private insurance. But we also know that the Affordable Care Act has done a number of things to make it easier for people on Medicaid to quit smoking. There are three really key ACA requirements about tobacco cessation. The first, pertaining to Medicaid, the first is requiring that all pregnant women have access to a comprehensive tobacco cessation benefit with no barriers. That includes all 7 medications and all 3 forms of counseling. It also there's also the section that expands tobacco cessation coverage for the traditional Medicaid population, removing tobacco cessation medications from the excludable list, meaning that all 7 medications should be covered for that traditional Medicaid population. And then expanding Medicaid, so increasing the Medicaid eligibility and making sure that that population has a comprehensive tobacco cessation benefit. And that benefit is part of the preventive services requirement, which was defined by the Treating Tobacco Use and Dependence 2008 update, which are the standard guidelines. However, we do know that tobacco cessation utilization is much lower than we would like it to be. Less than 10% of Medicaid enrollees that smoke actually use tobacco cessation medication, and we want to change that. So one thing that the American Lung Association did recently was we looked at what is happening in terms of promotion. And so we wrote a report about a month and a half ago, 2 months ago now, which I believe everybody was sent the link in some of the promotion emails. And if you haven't, please let me know. But there are 4 key takeaways from the report. And those 4 key takeaways were understanding Medicaid coverage, the Medicaid coverage landscape before you do any promotion, to build and sustain a close relationship with key allies and state Medicaid agencies, partnering with leadership at the organizational level, and then to develop a plan for evaluation. And so those are really some key things you can do when you as a state or as a nonprofit or as somebody who's just really interested in the issue is really trying to promote the benefit. And our report looked at both how to promote to beneficiaries but also how to promote to providers. So please let me know if you've got, so please feel free to look at the slides, and I'm going to turn it over to Rob Atzett now, who's going to talk a little bit about I'm going to turn it over to Rebecca Brooks, I apologize, who's going to talk a little bit about what the state of Vermont did to promote benefits to their providers. So Rebecca?
Hi, can you hear me?
Yep, we can hear you.
Okay,
and
great.
You should be able to toggle your own slides. Are you good with that?
Oh, okay. So, yes, it looks like I'm good with it. So I wanted to mention that in addition to being passionate about public health, I'm also passionate about ballroom dancing, and that's why the photo looked that way. So I have 15 minutes to tell you about a multi-year strategy to engage providers in tobacco counseling and referrals with a focus on smokers of low SES status. While this focuses on marketing and communications, we all realize that this is part of a larger strategy involving systems change through collaborations, the slide that was just presented with our state Medicaid office, and turning, for instance, turning on 2 out of 3 of the tobacco counseling CPT codes in January 2014 here in Vermont. Also involves trainings and strategic partnerships. And while focused on outreach to providers, I want to mention a change in our marketing strategy to smokers in 2012 when I first started working here. Previously, the program bought media for household income of up to $70,000, with the realization that at least half the smokers in Vermont were people of low SES and that the burden of tobacco fell most heavily on them. We revised our primary audience to be household income of up to $30,000, education of high school or less, and skewing male in the 18 to 24-year-old demographic. Since then, we've broadened the age to 25 to 34. I also want to note that we have a separate teen prevention campaign branded Down and Dirty with a focus on country teens who also use smokeless tobacco. So I am toggling and nothing's happening, so perhaps somebody could change the slide for me.
Okay, Rebecca, we'll do it for you.
Thank you.
Rebecca, this is Tamitha. I'm happy to do it.
Okay, great. So let's go back one more slide to 2013. Thank you. So back in the old days, before we rebranded cessation as 802 Quits, the Vermont Tobacco Control Program piggybacked on the CDC's National Talk with Your Doctor campaign as a method of reaching out to medical providers statewide, stressing the importance of their communication about cessation and increasing awareness of the free resources available to them. You'll see those bullets include some of the things we did. On the next slide, you'll see a collaborative mailing with Medicaid that we did to a broad range of providers, which included dentists and pharmacists, as well as PCPs, OBGYNs, and other providers. On the next slide, we're going to fast forward to 2014, and we rebranded our statewide cessation program 802 Quits after extensive primary research with our audience of low SES smokers. 802 is the only area code in Vermont, and it's really a point of pride. So in 2015, using the 802quits.org website as our central hub for all information related to quitting smoking and tobacco in Vermont, we focused our efforts on creating a robust resource for healthcare providers that was optimized for mobile. The Surgeon General report findings of the whole body impact of tobacco gave us a message platform. It allowed us to bring not only a sense of urgency to this effort, but also to broaden to a spectrum of healthcare providers that included mental health, oral health, reproductive health, and more. And for all, we emphasized that effective evidence-based tobacco control interventions continued to be underutilized. So this is where we began to create a branded suite of 802 Quits materials. On the next slide, and if you go to 802quits.org/providers, you can see a lot of the things I'm going to be talking about today. You'll be able to access the interactive map of the body. You can click on either an icon or a part of the body to learn more. On the next slide, you'll see the connection of smoking to dementia and Alzheimer's disease. You can see health consequences of tobacco on your eyes, heart, brain, lungs, teeth, and fertility, just to name a few. And in keeping with this bite, snack, meal concept of information, in each instance we link to either a fact sheet on our site to learn more, to an expanded toolkit, or to the CDC website to find more information on that particular topic. On the next slide, you'll see from the main landing page, we included resources specifically tailored to healthcare providers in the section called Resources for You. This page includes simple, easy-to-find tools, guidelines, and information so that providers support patients in their effort to quit tobacco and e-cigarettes, all of which are included in a downloadable digital toolkit they can save right onto their computer. On the next slide, also on the home page, you will see, let's see, one more slide forward. No, let's go back. I want to go back to the fax referral form. Yes, there we go. The message, taking just a few minutes to talk to your patients about smoking can double the odds of them successfully quitting, was prominently located on the site along with the fax referral form. Then on the next slide, you will see one of the many pages offering resources for providers. Again, you'll see on the next slide all the branded information that you have, the tobacco intervention tool, the NRT guidelines, downloadable fact sheets, and more, as the Ginsu knife says. Next slide, you will see, great. We encourage providers to order support materials for their practices right from our website. That includes waiting room and break room posters, the 5 A's, brochures on our Vermont Quit partners, those are in-person counselors, 802 rec cards, 802 Quit stickers, and the break room posters are for their offices. That's to reinforce in their break room their crucial role in all of this. On the next slide, we include information for providers to share with their patients with an appropriate lit level. These are all included in the downloadable toolkit. And on the next slide, we include webinar information so that providers who are looking to earn CMEs or CNEs can participate in an online educational activity right here on the site. And we again reinforce the importance of the CPT code information by calling special attention in a side navigation promotion that includes codes and definitions to streamline Medicaid reimbursement. On the next slide, you will see our online video strategy. That utilizes the credibility and peer-to-peer believability of healthcare providers. These are actual Vermont healthcare providers who delivers our content in direct, simple, and short vignettes of 3 to 5 minutes. These three are featuring Dr. Harry Chen, who is our commissioner and an ER doc, Dr. Walter Gundel, who is a well-known and respected cardiologist, and Dr. Jas Batra, who is the medical director of the Division of Mental Health. So, how do we get the word out about this? On the next slide, you'll see another mailing to all Vermont practices. Now, frankly, the jury is still out on mailing, and we can talk about that later during the question and answer. On the next slide, you will see other outreach that we have done. Ads in the Nurse Connection newsletter mailed to 17,000 nurses, and an email blast to all the state NPs with an open rate of 75 to 80%. So the heart of our provider promotion is really on the next slide, and that is our paid online campaign. It's based on research that online is where providers go for resources. We can advance the slide one more if we could. There we go. So we supported this campaign with paid media by running targeted PPC, that's pay-per-click, campaign that runs fall, winter, and spring and utilizes Google Display Network and Facebook. You'll see when you click on any of these ads online, they will take you to the provider section. And finally, on the next slide, we disseminate information about provider resources to our partners and coalitions. This helps us get the word out statewide. Here is just one slide from a webinar done with partners showing some of the resources and advice we give them to help them disseminate the promotion statewide. Okay, so what happened? On the next slide, you will see the results from our online metrics. Over a year, there's been a total of 1,556 provider toolkit downloads. Now keep in mind, these aren't downloads of individual tools. This is the entire toolkit. And the Office of Rural Health says that there is 1,922 total active physicians in Vermont. We can't prove that all of these downloads are from physicians or providers, but I'm not sure why you would do it otherwise. The 30-second Dr. Gundel video, which is promoted via the PPC campaign online, has had 8,334 views just this spring. And on average, people watch this video 93% of it. And paid traffic to 802quits.org providers on the resources page, where most of the content lives, people spend an average of over 3 minutes viewing the content online. Now, what the metrics tell us is that it appears we're reaching the right audience, they're engaging with our content, and they're using our resources and requesting more. Next slide is the result from our CPT code provider utilization. What we're seeing is a delivery of cessation counseling to Medicaid-insured Vermonters is increasing among providers. There was a 44% increase in CPT code utilization when comparing 2014 to 2015. And based on the first quarter of results from 2016, we're optimistic that there might be a further increase in CPT code use this year. Now, let me say that's the language our analyst is comfortable with. The data increased so much in the first quarter of 2016 that we want to investigate this before we say any more. So at this point, I'm actually going to turn over the rest of the results and the next steps to Rhonda Williams.
Thank you very much, Rebecca. So I'm going to continue with what we're seeing on our quit line. Next slide, please. So what we see in our data is an increase in proportion of Medicaid tobacco users in terms of total calls, total registrants, and total coaching calls. For example, our Medicaid tobacco users were 16% of our total quit line registrants in 2013. This grew to 27% in 2015. This growth occurred even when we saw, unfortunately, the total registrants, quit line registrants decrease in 2015. However, we are encouraged that we are serving more proportionally of our targeted demographic. We've also seen a similar increase in total coaching calls among our Medicaid insured. Next slide, please. The program has prioritized evaluation of our Medicaid beneficiary and provider efforts in our 5-year strategic evaluation plan. We are now at the point of using the first round of evaluation results to put into our fiscal year 17 promotion work plan with Medicaid. We are doing more outreach with providers, or we will be doing, through select key informant interviews, in addition to a discovery session with some of Vermont's experts to find out what adjustments we may need to make to our 802 Quits provider page and resources. We definitely recognize that this is an iterative process in meeting our engagements where they are, our provider base where they are at. We also have seen underutilization among healthcare centers. These are centers that see high numbers of Medicaid insured. And therefore, we're planning for customized communications to increase awareness and, over time, utilization of the CPT codes. Next slide, please. We are also using our strategic partnerships and relationships, including with providers, our Medicaid medical director, our Blue Cross Blue Shield medical director, and other health systems leaders to promote more effectively on how to use the CPT codes. We are also leveraging our health systems' interests in improving asthma and COPD care and their interest and commitment to reducing hospital readmissions. And so we've seen an increased interest in the CPT codes. So that's an area that we have found encouraging to work on, in particular over the last year. And then the next slide, in terms of health systems. So with our last slide, we just wanted to highlight that as a state, we're continuing to communicate on the need for our state's essential health benefit to be as strongly aligned with the Affordable Care Act as possible. We're not there yet, but we're continuing to work on it. We're also continuing to focus on how our largest accountable care organization, called OneCare, for it to change tobacco use and counseling from a reporting measure to a payment measure. We are continuing to increase the quality and the quantity of tobacco treatment specialists to enable integration of tobacco treatment into clinical, behavioral health, and community-based settings. So I think I will stop there and hand it over to Tamitha, leaving us a couple extra minutes for questions should they be needed later.
That's perfect. Thank you both, Rebecca and Rhonda. And it does look like we have a question about the work Vermont has done to reach out to behavioral health providers. Have you done that work like you did when you were reaching out to general health care providers?
Yes, that's a great question. So for several years now, we have done it through a policy and a practice approach. So we set an expectation that the facilities funded by our Department of Health would become tobacco-free campus by a certain date. Simultaneously, we provided technical assistance, examples of a treatment plan. We brought in several national experts in behavioral integration of tobacco to work with our providers, the clinical care directors, even the administrators themselves and frontline staff, recognizing that it's a cultural shift as well as a practice shift. And we continue the work now, including obesity as part of a culture of wellness approach. So we're still very engaged in that line of practice.
That's great. Good. So we do have a few more questions in the queue, but I want to move to Rob so that he has time to do his presentation, and then we'll circle back and take questions both for our colleagues in Vermont as well as Rob. So thank you so much again to Rebecca and Rhonda, and at this point I'll turn it over to Rob.
Thanks, Tamitha, and good afternoon, everybody. So over the next few minutes, I'm going to talk about the Wisconsin Medicaid program and how we worked with the program to increase provider knowledge and accurate knowledge about the tobacco cessation benefits, which then in turn helped drive up utilization by Medicaid members. So no surprise to anybody on this call, but Medicaid members in Wisconsin smoke at more than double the rate of the general adult population. Importantly, our Medicaid program has always been really interested in helping their members quit. We've had probably close to a 20-year relationship with our state Medicaid program now, and they have, that entire time always taken tobacco use really seriously among their members. So that helped a lot and continues to help our work around tobacco cessation benefits and coverage. So our campaign is about a decade old now, and back then individual counseling was covered when provided by a clinician. All the FDA-approved medications except nicotine lozenge was covered, including combination therapy. And I'm happy to say that earlier this year, earlier in 2016, our state Medicaid program added coverage for nicotine lozenge, so now it covers all of them. All the medications require a written prescription from a Medicaid certified provider, and that includes even over-the-counter medications. And then repeat courses of treatment are allowed. So back then, less than 2% of our Medicaid members used the tobacco cessation benefits, and the members themselves often reported to us that they weren't aware that coverage was available to them to help them quit, and many didn't know, what those benefits or treatments are. And similarly, the clinicians and health plans were typically pretty unclear about the coverage for Medicaid members. And with clinicians, I also include pharmacists. We had a number of examples of pharmacists turning away Medicaid members when they came with a prescription, telling them that the Wisconsin Medicaid program didn't cover the nicotine patch or whatever the medication was. And of course, the member then just walks away. Most times they don't have the means to, pay for the medication by themselves. So our campaign was called Medicaid Covers It. Really, clinicians were the primary target, clinicians and health systems and health plans. Secondarily, we targeted members, and our goal was to dispel the myths, increase consumer demand, and then ultimately increase utilization of the benefits. But really, the primary goal was to get accurate and up-to-date information out into people's hands. So the campaign development included, we knew the need was there. People were misinformed or not aware of the tobacco cessation benefit. We held key informant interviews, both with Medicaid members, but also with Medicaid certified providers and health plan staff. We worked really closely, of course, with our state Medicaid program staff, and we developed the messages and materials in collaboration with them. And we actually piloted a small pilot of the Medicaid Covers It campaign prior to launching it statewide. Interestingly, I will also say that our state Medicaid program funded this whole project. the interviews, the development of the materials, the production of the materials. And again, it's just one more example of how they are really serious about helping their members who use tobacco to quit. So the message to healthcare providers, Wisconsin Medicaid has changed. It's tobacco cessation coverage. It's simpler and it's better. To consumers, if you are a Medicaid member, you can afford to quit because Medicaid covers it. So how did all this information get out to people? And I'm going to show you some of the materials in the next few slides. But really, they were fact sheets. We knew they needed to be concise and brief. And again, the purpose was to dispel the myths and get accurate information out there. The state Medicaid program sent it out in their electronic newsletter, which they use to communicate policy and program changes. And it goes to every Medicaid certified provider in the state of Wisconsin, which is thousands of clinicians. We developed a PowerPoint slide set, both primary care and mental health and substance abuse providers focused, articles for professional organizations and health plans to use, and then brochures and posters in both English and Spanish that you'll see on these next few slides. So the clinician resources, this was actually a folder. So again, this was about a decade ago. We did produce print material. We probably wouldn't do that in this day and age, but we did at the time. And there were specific fact sheets for the people in the expanded bullet there, the billing staff, patients, pharmacists, and healthcare providers. And within healthcare providers, we included primary care and then materials specifically for substance abuse and mental health providers. Here are some of the materials. The green you see there is circled for pharmacists. The bluish color is for healthcare providers. And again, we in kind of bullet form just laid out, here is what's covered for Medicaid members in the state of Wisconsin, and information about coding and billing and how do you get reimbursed for providing the counseling or the medications. Here were posters. These were targeted at members. And again, we distributed these far and wide. We also made them available to Medicaid contracted HMOs that they could provide to their clinicians. We also made all these materials available to individual clinicians or clinics or hospitals that see Medicaid members. Here was a brochure for members, and again, kind of very bulleted, simple form with the message that you really can afford to quit smoking. Medicaid covers it. So just laying out what is available for them to help them quit using tobacco. In our evaluation, just quickly mention that before the campaign, there was a slow and steady decline in claims for tobacco cessation medications, and post-campaign there was a pretty good increase in those claims. So what difference did it make? So the medication claims tripled from about 1.5% of adult Medicaid members who smoke before the campaign to about 4.5% after the campaign. We tracked quitline registrations, and pre-campaign it was about 60 a month, and post-campaign about 95 a month. So again, about a 60% increase in Medicaid members using our Wisconsin Tobacco Quitline. And there were some limitations. We weren't able to, there was no data on physician counseling claims. It was difficult to extract from the Medicaid claims data. The pharmacotherapy used is a pretty conservative estimate because we excluded bupropion from the analysis because there was no way to differentiate between bupropion for smoking cessation versus depression. And finally, the Wisconsin Tobacco Quit Line, it's self-report, so Medicaid members self-report that they are Medicaid, and of course not all callers are willing to provide that information. So just to conclude, it contributed, this campaign, Medicaid Covers It, contributed to a significant increase in tobacco cessation medication claims for Medicaid adult members, and it also increased the number of Medicaid members who were not just calling the Wisconsin Tobacco Quit Line, but enrolling and registering for services. Here is an article that we published on the evaluation of the project in the American Journal of Health Promotion. All the materials for our campaign are available on our website at that web address, and I believe these slides will be shared so you don't have to worry about writing down that URL. You'll be able to get them after the webinar in slides. And then finally, this is our website, again, where our regional outreach staff drive thousands of clinicians to the resources that are available on our website, including the Medicaid Covers It materials. And I'll turn it back to you, Tamitha.
Excellent. Thank you so much, Rob. Thank you, thank you. So Rob did just say that the slides would be available, as will a recording. Anne, I'm going to ask you if you could share with the group quickly when that might be and how to access them.
Yeah, so we will obviously send a follow-up email to anybody who's registered for the webinar. We can work with, hopefully we can attach the slides to that email. The recording of the webinar should be available probably in about a week or a week and a half. You can find that along with a number of our other resources at our Cessation TA website, and that's www.lung.org/cessation-TA. And then there's a section called recorded presentations or recorded webinars. And if you go to that section, it's under the Medicaid section. But I will type in the email address in the Q&A box so everybody can see that. And we'll make sure to include that, that general email address in that follow-up email as well.
Great. Thank you. So we have quite a few questions, so this is exciting. I want to go back to something, Rebecca, that you mentioned, which is that the jury is still out on the mailing. I'm wondering if you could expand on a little bit on that, the pros and cons on the mailing, the toolkit versus the digital toolkit.
Sure. And I will say we are waiting for some imminent research here with colleagues in the opioid division here who are doing some research with providers on the very best way for them to access information. But this is based on some focus groups that I did a couple of years ago nationally with providers who basically told me if it's not online, we're not going to see it. So we continue to do the mailings. We're a rural state. We're not sure that the mailings are really the very best way to reach people. But what we're hoping to do with these in-depth interviews with our providers is to find that out exactly. What we are seeing is an enormous amount of response with our online and with our digital downloading for information. So my guess is that that might be a much more cost-effective way to go.
And how did you, Rebecca, notify providers about the digital toolkit?
Well, we did a number of things. We did do a mailing. We mailed all practices. We also, as Rob had mentioned, we are mentioned in the Medicaid newsletters both to beneficiaries, and I believe they're called bulletins to the providers. So we were able to get some things out that way, as well as, you know, a lot of what we did was online. We used Google and Facebook to let docs know that the toolkit was available.
Great. Thank you. Thank you. Thank you. Rob, I have a question for you about the benefits specifically. Is there a number or a limit on the number or frequency of repeats for prescriptions?
There is not. Our state Medicaid program allows unlimited cessation attempts and prescriptions to over that.
Great. And, you know, you mentioned, so the end of your presentation, Rob, there was this amazing graph using the claims data. Can you talk a little bit about getting access to claims data, working with Medicaid? Who are you working with to get that data?
Yeah, so again, for probably 15 years or so, our state Medicaid program has had a staff person focused on tobacco and tobacco cessation, tobacco use and tobacco cessation. And through working with her, she could make requests for data pulls from the company that keeps all of our Wisconsin Medicaid data. And so it was fairly easy for us because we had a person within the Medicaid program that could request that kind of information. I'll also say that our state Medicaid program for, I don't know, 5, 6, 7 years now has had a pay-for-performance project, one specifically focused on tobacco cessation, again, to try to increase utilization of the benefit.
Great. Thank you. Thank you. And how are you, Rob, working with Medicaid managed care? Do all of those plans also cover all of the medications, or are you seeing plans vary?
Yeah, so in Wisconsin for a long, long time, we've been primarily just managed care. So we've worked with them all along. There's a bit of a funky thing that started, again, maybe 6 or 7 years ago. Our state Medicaid program went to a pharmacy benefit management company. So actually all the meds now go through that and not through the HMOs and MCOs. But again, it's just a matter of, you know, how they're kind of distributed.
And how about Rhonda and Rebecca in Vermont? Can you talk a little bit about the benefit in general? So is there work on to reduce copays, but then also what you're seeing in terms of managed care plans?
Yeah, this is Rhonda. So when we started in close collaboration with our Medicaid team about in 2012, we identified 2 of the barriers, one of them being copays and the other prior authorization that we wanted to tackle. And the Medicaid team was willing to have a set of discussions around those and look at the guidance surrounding it, but said no can do. And we are thinking of trying to readdress these in the next year or 2. So we haven't been able to remove those barriers. However, the NRT benefit has been robust for a number of years, at least for the last 8 years. Includes all of the NRT and benefit, bupropion and varenicline as well. The copays are $1 to $3. And we were able to, in 2014, as we looked at how we were delivering NRT through the quit line, we saw that we could make improvements in terms of doing it equitably to Medicaid beneficiaries as well, because before that we had sent them to get their NRT only through their provider. We didn't provide NRT to Medicaid beneficiaries. So we changed that, and we also, with the Cochrane reviews that came out that showed strong evidence for using dual. We changed our NRT delivery through the quit line to as a preferred option that it's dual, short and long acting together. We then asked Medicaid to do the same through their pharmacy benefit, and they changed as well.
So, Tamitha, this is Rob. That reminded me to add something else. So all of the Medicaid contracted plans and providers and MCOs in the state of Wisconsin, they're required to cover this base, this is the minimum you have to cover for tobacco cessation, and that now includes all 7 FDA-approved medications as well as counseling. And our copays are 50 cents and $1, depending on generic or brand name. And so Vermont's comment made me think of that.
Yeah, good. So we do have a question, I think, building on this a little bit. So in Oregon, Robin states that the quitline participants differ in their level of benefits. So Medicaid enrollees only get 2 weeks of NRT, whereas private pay may get, as we all know, many more weeks than that, and uninsured registrants get 4 weeks. So I'm just wondering, I remember, Rhonda, you and I talking when we were working on the Promising Practices Guide around Vermont, really seeing this as a disparity issue and really working that as a way to align some agendas. I'm just wondering if you wanted to build or add to that.
Yeah, you say it well, Tamitha. We then aligned that the Medicaid benefit for coming through the quit line, quit online, or quit in person would all be 8 weeks of dual, and that would also be in addition to what they can access through their Medicaid benefit, which is 16 weeks of NRT. Our Medicaid office will extend additional coverage, NRT support, on a case-by-case basis, and we do try to get the word out about that because we do know that there are some individuals, we see this in our Quit in Person program, that need ongoing support. And so that's important for us to keep on messaging.
Nice. Thank you. And we do have a question, just quickly, Rebecca, you mentioned very briefly the Youth in the Country program. I'm wondering if you could just provide us with a link or some information so that folks who are interested could learn more.
Sure. It is downanddirtylife.com, and it's on Facebook. And that is a program that was begun here in Vermont with primary research because we have a lot of teens involved in smoking and chewing. And as it turns out, the peer group that does the most of it identify with country or rural, hunting, mudding, fishing. And this program is now shared in Virginia, Mississippi, and I just got a call today from Arkansas about it. They're hoping to institute it as well. So I believe it's just downanddirtylife.com, but I can send it to you if that's not the correct one. I'll look it up and send it on to you.
Okay, excellent. Good, so we've got about 5 minutes left in the call, and it looks like we've almost gotten through all of the questions. I did want to just ask if there was any, if either state has any sense of, everyone is always very interested in the cost of all of this. And so I'm wondering if either Vermont or Wisconsin has anything to share that could give folks some sense of not only the funding stream perhaps that was used to pay for these activities, but just maybe a ballpark in terms of cost.
Yeah, so this is Rob in Wisconsin. Our state Medicaid program funded the Medicaid Covers It campaign from start to end. And I don't have the number right in front of me, but it was under $10,000 for sure. Between probably $5,000 and $10,000. So not very much of a capital outlay for them.
So this is Rebecca in Vermont, really wishing I lived in Wisconsin. We are funding all of our own, although Medicaid has provided us with data sharing and with partnerships, which is fascinating and wonderful. And they have given us the mailing list. Now, when it's hard to tease this apart because we do mailings to beneficiaries, which can be quite expensive. But for the website itself, just for the providers, I would say it's been around $20,000 to $25,000 to build it and to maintain it. Now that cost will tail off because, as you know, building a website is pretty front-loaded expense, but we still need to constantly maintain it, and it's interesting. We want to keep updating resources. It's got to be fresh. If you're online, it's got to be fresh.
And just in terms of the Medicaid mailing to beneficiaries, do you want to mention that, Rebecca, in terms of the 2 years we did that?
Yeah, it's around $45,000 for $45 to $50 for mailings to our Medicaid beneficiaries. We saw an enormous spike in calls to the quit line immediately after we did both these mailings both years, and we also saw a spike in the requests for quit tools, putty, little distraction tools here. So we know they're very effective. I think it helps a great deal that it comes from Medicaid. That's the return address.
You bet. Great. Thanks to all three of you. So with 3 minutes to go, I would love to hear your, Rebecca, you mentioned the bite, snack, meal approach, and I'm going to say bite, snack, meal, and dessert. So if you were going to offer up dessert to the audience this afternoon, on this topic, what would you offer? So I'll ask Rebecca and Rhonda to go first.
Okay. I'd say that the key to any kind of successful marketing is to make it as simple as possible. Figure out what all the barriers are and get rid of as many of them as you possibly can. And, that's what we did with the providers, and that's what we need to continually do. Our research will never be over.
That's excellent. And I would just add that and marry it with policy so that they can support each other in both having the marketing but also the policy to whether expand the benefit or reduce obstacles to it.
Awesome. Yes, that policy and practice approach, Rhonda, that's wonderful. Good. And Rob, your dessert offering to the group.
Yeah, so two things. I agree completely with removing the barriers, and that's both financial barriers but also access. How does a Medicaid member access these tobacco cessation benefits? And then over the years, one thing that's driven Medicaid's interest in maintaining their interest in tobacco cessation is when they query the cost of smoking-related diseases and deaths that they're paying for. It's 10% or around 10% year in and year out, and in $1 billion plus budget, that's a lot of money. So they're not only driven by the cost, they're also, of course, interested in helping their members to be healthier.
You bet. Great. Well, with that, we say thank you. Anne, do you want to say any final words to someone?
Yeah, I just thanks so much, Tamitha. Thank you for hosting and moderating this wonderful webinar, and thank you, Rob, Rebecca, and Rhonda for your sharing what you've done and all the great work you guys have done in your state and everybody else. please let me know if you guys have any questions or concerns, and we will try to get those slides out to you as soon as we can, and then the webinar, the recording will be up. So if you want to forward it to colleagues or friends or family who might want to see this, please feel free.
Thank you. Thanks so much, everyone. Have a good rest of your week. Take good care. Bye-bye.
Bye. Bye.